Your knees are sending you a message. You hear it when you get up from a chair. You feel it on the stairs. You notice it on the morning when the stiffness takes longer to ease than it used to, and you recognize, somewhere in the back of your mind, that this is not just a bad day, that this has been getting slowly, quietly worse. If you are over 50 and arthritis is affecting your knees, what I am about to share with you is the most important thing you can do starting today, and it is not rest. It is not waiting. It is not accepting that your knees will simply continue to get worse. It is 7 specific exercises, performed every day, that the research in orthopedics and exercise science has identified as the most effective movement-based interventions for protecting knee cartilage, reducing knee arthritis pain, and rebuilding the muscular support that arthritic knees lose and desperately need. I am going to walk you through each exercise, what it is, how to do it, how many repetitions, and most importantly why it works at the biological level of joint mechanics and cartilage physiology. Because understanding why an exercise helps your knees is what turns it from something you are told to do into something you choose to do every single day because you understand exactly what it is doing inside your joints. Before we begin, if you want more evidence-based guidance for managing arthritis and joint health after 50, subscribe to this channel right now. We create this content specifically for adults over 50 who want real answers from real science. Hit subscribe and never miss a video that could change how you move and how you feel. Now let us start with the biology, because before we talk about the 7 exercises, you need to understand what is actually happening inside arthritic knees and why movement, the right kind of movement, done consistently, is the single most powerful intervention available to protect them. Knee osteoarthritis, the most common form of arthritis affecting the knees in adults over 50, is a disease of cartilage loss. The articular cartilage that covers the ends of the femur, tibia, and patella, providing the smooth, low-friction surface that allows the knee to flex and extend through its full range of motion without pain, gradually thins and breaks down under the combined influence of mechanical stress, inflammatory signaling, and the progressive decline in chondrocyte repair activity that accompanies aging. Cartilage has no blood supply. As we discussed in our previous arthritis videos, it receives all of its nutrients through the diffusion of synovial fluid, the viscous lubricating fluid that fills the joint space. This diffusion depends on movement. The compression and decompression of cartilage that occurs with every bend of the knee pumps synovial fluid into and out of the cartilage, delivering oxygen, glucose, and the specific growth factors that chondrocytes need to maintain and repair the cartilage matrix. When people with knee arthritis reduce their movement because of pain, which is the natural and understandable response to a joint that hurts when it moves, they inadvertently reduce the synovial fluid circulation that cartilage nutrition depends on, accelerating the degeneration they were trying to protect against. This is one of the most important and most counterintuitive facts in knee arthritis management. Resting an arthritic knee does not help the cartilage. Moving it in the right way, at the right intensity, with the right exercises does. The second reason movement is critical for arthritic knees is the muscle dimension. The quadriceps muscles of the thigh are the primary dynamic stabilizers of the knee joint. They absorb the mechanical forces that would otherwise be transmitted directly to the articular cartilage surface with every step. When quadriceps strength is adequate, the knee joint loads are distributed efficiently, and the cartilage experiences manageable stress. When quadriceps strength is reduced, as it consistently is in adults with knee arthritis, partly because pain inhibits quadriceps muscle activation, the knee joint becomes mechanically inefficient, concentrating load on smaller cartilage areas and accelerating the wear that drives arthritis progression. Research published in Arthritis and Rheumatism found that each pound of quadriceps strength lost was associated with a specific increase in the risk of knee osteoarthritis progression, and that quadriceps strengthening through exercise produced measurable reductions in knee joint pain and improvements in physical function in randomized controlled trials of adults with established knee osteoarthritis. The hip abductors, the muscles on the outer hip that control the alignment of the leg during single leg weight bearing, influence the biomechanics of the knee joint in a clinically important way. When the hip abductors are weak, the femur internally rotates during walking, increasing the stress on the medial compartment of the knee, the inner portion of the knee joint most commonly affected by osteoarthritis. Strengthening the hip muscles alongside the quadriceps produces a whole limb biomechanical improvement that reduces knee joint loading more effectively than quadriceps strengthening alone. The 7 exercises we are about to walk through address all of the critical dimensions of knee arthritis management through movement. Cartilage nutrition through synovial fluid circulation, quadriceps strengthening for joint load management, hip muscle strengthening for whole limb biomechanics, range of motion preservation for functional joint health, and neuromuscular control and proprioception for fall prevention and joint protection during daily activities. The first exercise is the seated leg extension. Sit in a sturdy chair with your back supported and your feet flat on the floor. Slowly straighten one leg until it is parallel to the floor, or as close to parallel as your knee allows without discomfort. Hold for 3 to 5 seconds with the quadriceps actively contracted, then slowly lower the foot back to the floor. Repeat 10 to 15 times on each leg, for 2 to 3 sets. The seated leg extension is the foundational quadriceps strengthening exercise for knee arthritis because it allows the quadriceps to be contracted and strengthened through its full available range of motion, without the joint compression that standing exercises produce. It activates all four quadriceps muscle heads, particularly the vastus medialis oblique, the teardrop-shaped muscle on the inner lower thigh, that is specifically important for maintaining proper patellar tracking. Research published in the Journal of Rheumatology found that a progressive quadriceps strengthening program beginning with seated leg extensions in patients with knee osteoarthritis produced significant reductions in pain scores and significant improvements in walking speed and stair climbing ability over 12 weeks, with the improvements sustained at 24-week follow-up. The second exercise is the straight leg raise. Lie flat on your back with one knee bent and the foot flat, and the other leg straight. Contract the quadriceps of the straight leg, pulling the toes toward you and tightening the thigh muscle, and then raise the straight leg to approximately the height of the bent knee. Hold for 2 to 3 seconds, then slowly lower. Perform 10 to 15 repetitions on each leg for 2 to 3 sets. The straight leg raise strengthens the quadriceps and hip flexors simultaneously, without placing any compressive load on the knee joint, making it the most joint-friendly quadriceps exercise available, and the one most appropriate for adults over 50 with significant knee pain who find the seated leg extension uncomfortable. The third exercise is the clamshell. Lie on your side with both knees bent to approximately 45 degrees, one hip stacked directly on top of the other. Keeping the feet together, rotate the top knee upward like a clamshell, opening as far as you can without the pelvis rolling backward. Hold at the top for 2 to 3 seconds, then slowly lower. Perform 15 to 20 repetitions on each side for 2 to 3 sets. The clamshell specifically targets the gluteus medius and gluteus minimus, the hip abductor muscles whose strength determines the valgus stress on the knee during walking. A study published in the Journal of Orthopedic and Sports Physical Therapy found that an 8-week hip strengthening program that included clamshell exercises significantly reduced knee pain and improved knee function in adults with patellofemoral pain syndrome, with the improvements attributed specifically to the reduction in dynamic knee valgus that hip abductor strengthening produces. The fourth exercise is the standing wall slide. Stand with your back against a smooth wall, feet approximately 30 centimeters from the wall and shoulder width apart. Slowly slide down the wall by bending both knees to approximately 30 to 45 degrees, never beyond 90 degrees, and ideally stopping at whatever angle feels comfortable. Hold for 5 to 10 seconds, then slide back up. Perform 8 to 12 repetitions for 2 to 3 sets. The wall slide is a closed kinetic chain exercise, one in which the foot is in contact with a fixed surface during the movement, which produces a different quadriceps strengthening stimulus than the open kinetic chain seated leg extension. Closed kinetic chain exercises distribute the loading force across the entire knee joint more evenly and produce co-contraction of the hamstrings alongside the quadriceps, improving the overall dynamic stability of the knee. The wall provides support that reduces the balance demand and allows precise control of the knee angle, with the critical instruction to keep the knee bend within a comfortable range and never to force the knee into a range that produces pain. Before we continue with the final 3 exercises, here is a pause for you. Are you currently doing any form of regular knee strengthening exercise for your arthritis, or has your main strategy been to rest and avoid activities that cause pain? Drop a comment below right now and be honest with us. So many adults over 50 with knee arthritis are stuck in the rest and avoid cycle that actually accelerates the damage they are trying to prevent. Your honesty here helps this community understand what we need to address next. We read every comment. The 5th exercise is the seated heel slide. Sit in a chair with both feet flat on a smooth floor. Slide one heel forward by straightening the leg, feeling the knee extend through its available range of motion, then slide it back. The motion should be slow and controlled, taking 3 to 4 seconds each way, and should produce a gentle stretch rather than pain. Repeat 15 to 20 times on each leg for 2 to 3 sets. The heel slide specifically targets range of motion, the ability of the knee to move through its full arc of flexion and extension, which is one of the first functional capabilities that knee arthritis restricts. Maintaining range of motion is critical for functional independence in adults over 50 with knee arthritis because the activities of daily life require specific minimum knee flexion and extension ranges that, if lost to stiffness, produce significant disability. The slow, repeated movement of the heel slide also serves as a cartilage nutrition exercise. The gentle cyclical compression and decompression of the joint during the slide pumps synovial fluid into and out of the cartilage. The sixth exercise is the standing hip abduction. Stand beside a wall or sturdy chair for balance, feet hip-width apart. Keeping the legs straight and the body upright, slowly lift one leg out to the side to approximately 30 to 45 degrees. Hold for 2 to 3 seconds. Then slowly return. Perform 15 to 20 repetitions on each side for 2 to 3 sets. The standing hip abduction provides the same hip abductor strengthening benefit as the clamshell but with the added element of single leg standing, which engages the proprioceptive and neuromuscular control systems of the standing knee. Proprioception, the joint's ability to sense its own position in space, is significantly impaired in knee osteoarthritis, with research demonstrating that the loss of proprioceptive accuracy in arthritic knees is a significant predictor of fall risk and of knee buckling during daily activities. The standing hip abduction simultaneously strengthens the hip muscles and retrains the neuromuscular control of the supporting knee. The seventh exercise is the seated knee extension with isometric hold. Perform the seated leg extension as described in the first exercise, but when the leg reaches full extension, hold the contraction at maximum effort, squeezing the quadriceps as hard as comfortably possible for 30 to 45 seconds before slowly lowering. Perform 3 to 5 isometric holds on each leg. The isometric hold produces the post-isometric hypotension effect we discussed in detail in our Japanese blood pressure video. The sustained sympathetic nervous system shift toward parasympathetic dominance that produces a reduction in pain sensitivity following the isometric contraction. Research published in the British Journal of Sports Medicine found that isometric quadriceps contractions of 30 to 45 seconds duration produced immediate reductions in knee pain that lasted for up to 45 minutes in patients with patellar tendinopathy and knee osteoarthritis. For adults over 50 with knee arthritis who experience significant pain with exercise, the isometric hold provides a daily pain management tool that simultaneously strengthens the quadriceps. The pain avoidance cycle that traps most adults over 50 with knee arthritis deserves specific and honest discussion because it is the most important behavioral barrier between where most people with knee arthritis are and where the research consistently shows they could be. The cycle operates like this. The knee hurts. Movement makes it hurt more. So movement is reduced. Reduced movement means reduced quadriceps activation, and research has documented that pain itself directly inhibits quadriceps muscle activation through a neurological mechanism called arthrogenic muscle inhibition, in which pain signals from the joint suppress the motor neurons that control the surrounding muscles. Reduced quadriceps activation means reduced muscle strength. Reduced muscle strength means less dynamic joint protection, increased joint loading per step, and faster cartilage degradation. Faster cartilage degradation means more pain. More pain means further movement reduction. The cycle accelerates its own progression. Breaking this cycle requires understanding that the short-term discomfort of beginning an appropriate exercise program for knee arthritis is not evidence that the exercise is causing damage. The research is consistent. The initial weeks of a knee exercise program for osteoarthritis are the most uncomfortable, and the patients who push through this initial period gradually within their tolerance, with appropriate modifications, experience significant pain reduction and functional improvement within 4 to 8 weeks that those who quit in the first week never achieve. The specific pain threshold to work within is the 2 out of 10 rule. Exercise within an intensity that produces no more than mild discomfort during the movement. If an exercise produces more, modify it, reduce the range. Switch to a more joint-friendly variation, but do not stop moving. For adults over 50 with knee arthritis, who find even modified versions of the standing exercises too painful to begin, aquatic exercise provides a gateway into the movement that arthritic knees need without the weight-bearing load that makes land-based exercise initially prohibitive. In water, buoyancy reduces the effective body weight on the knee joint by approximately 50% when immersed to the waist. This dramatic reduction in joint loading allows the muscles around the knee to be exercised through their full range of motion with minimal joint pain, building the quadriceps and hip abductor strength that the land-based program requires while the joint is protected. A Cochrane review of aquatic exercise for lower limb osteoarthritis found that water-based exercise programs produced significant reductions in pain and significant improvements in physical function and quality of life in adults with hip and knee osteoarthritis, with effect sizes comparable to those of land-based exercise programs. For adults over 50 with knee arthritis, who cannot yet tolerate the land-based 7 exercise program, beginning with a water exercise program and gradually transitioning to the land-based program as strength and pain tolerance improve represents the most appropriate progression. A systematic review published in the Cochrane Database of Systematic Reviews, the gold standard of evidence synthesis in clinical medicine, examined the effects of exercise therapy on knee osteoarthritis across 44 randomized controlled trials involving more than 3,500 patients and found that exercise therapy produced significant reductions in pain, significant improvements in physical function, and significant improvements in quality of life, with moderate to large effect sizes that were comparable to those of analgesic medications without the side effects. The complete daily sequence is performed in this order: seated heel slide for range of motion preparation, 5 minutes of gentle joint warming, straight leg raise 10 repetitions each leg to sets, clamshell 15 repetitions each side to sets, standing hip abduction 15 repetitions each side to sets, seated leg extension 12 repetitions each leg to sets, wall slide 10 repetitions to sets, seated knee extension with isometric hold 3 holds of 30 to 45 seconds each leg. Your knees will respond to how you treat them. They are not passively deteriorating regardless of what you do. They are actively responding to the mechanical and nutritional inputs you provide every day. Movement provides cartilage nutrition and muscle protection. Strength reduces joint loading. Proprioceptive training prevents falls. Daily practice consolidates the neuromuscular adaptations that turn these exercises from effortful interventions into automatic behaviors. The 7 exercises in this video are not heroic. They are not time-consuming. They do not require equipment, a gym membership, or a fitness background. They require 30 minutes every morning, and the understanding that what you are doing every single repetition is investing in the functional independence, the freedom of movement, and the quality of life that your knees and your body are asking you to protect. The biomechanics of the knee joint during daily activities, walking, stair climbing, rising from a chair, are worth understanding in specific terms, because the 7 exercises we have described are designed to address the exact mechanical vulnerabilities that these activities exploit in arthritic knees, and knowing this connection reinforces the daily practice. During level walking, the knee joint experiences a loading force of approximately 2 to 3 times body weight with each step. During stair climbing, this loading increases to approximately 3 to 4 times body weight. During the act of rising from a seated position, the movement that most adults with knee arthritis identify as one of their most symptomatic daily activities, the knee joint load, can reach 5 to 6 times body weight as the quadriceps generates the force to lift the body against gravity. For an adult weighing 70 kilograms, this represents a joint contact force of 350 to 420 kilograms concentrated on a cartilage surface that may already be thinned, irregular, and less able to distribute these forces evenly. The quadriceps strengthening exercises, seated leg extension, straight leg raise, wall slide, and isometric hold, are specifically designed to increase the force generating capacity of the quadriceps muscle group so that when these daily loading events occur, the muscle is absorbing more of the force and transmitting less of it to the cartilage. Research has quantified this relationship. Each 10% increase in quadriceps strength in adults with knee osteoarthritis is associated with a specific reduction in the peak knee joint contact force during walking, a biomechanical improvement that is directly protective of the articular cartilage surface. The hip abductor strengthening exercises, clamshell and standing hip abduction, reduce a specific type of knee joint loading called the knee abduction moment, the rotational force that pushes the medial compartment of the knee toward ground during single leg stance. The knee abduction moment is the most clinically important predictor of medial compartment osteoarthritis progression in research literature, and reducing it through hip abductor strengthening is a validated biomechanical strategy for slowing articular cartilage loss in the most commonly affected knee compartment. The proprioceptive training component of the standing exercises, building the neuromuscular control of knee position during single leg stance, reduces the frequency of the unexpected joint loading events that occur when the knee buckles or shifts during normal walking. These unexpected loading events, the sudden shifts in knee alignment that arthritic knees experience when proprioceptive control is impaired, produce concentrated contact forces on specific small areas of cartilage that are among the most damaging mechanical events in osteoarthritis progression. Improving proprioception through the consistent practice of single-leg standing reduces the frequency of these events and protects the cartilage from the concentrated focal loading they produce. The pain physiology of knee arthritis exercise deserves additional explanation, specifically the central sensitization mechanism that explains why some adults with knee arthritis experience pain that is disproportionate to the apparent structural damage visible on imaging, and why exercises that address this central sensitization component rather than simply strengthening muscles may be particularly valuable for this subgroup. Central sensitization in knee arthritis occurs when the persistent pain signals from the arthritic joint sensitize the dorsal horn neurons of the spinal cord, lowering the threshold at which pain is perceived and widening the area of pain distribution. In a sensitized pain system, movements and pressures that would not normally produce pain do so, and the exercise that would be tolerated well by a person without central sensitization produces disproportionate pain in the sensitized patient. This is why some adults with relatively mild structural knee arthritis experience severe pain, while others with more advanced structural damage experience surprisingly manageable symptoms. The isometric hold exercise addresses central sensitization through its documented effect on conditioned pain modulation, the body's own descending pain inhibitory system that, when activated by sustained isometric contraction, reduces the sensitivity of the dorsal horn neurons and provides an analgesic window that extends well beyond the exercise session itself. For adults over 50 with knee arthritis whose pain seems disproportionate to the level of activity or structural damage, whose pain is widespread, severe with light touch, or accompanied by significant fatigue and sleep disturbance, the isometric hold exercise is particularly important, and its pain modulating benefits may exceed those of any other component of the program. The integration of nutrition and exercise for knee arthritis after 50, which we have built across the 3 arthritis videos in this series, creates a synergistic effect that neither approach achieves alone. The anti-inflammatory morning foods from our prevention video reduce the inflammatory cytokine environment in which the knee exercises are performed, meaning the quadriceps activation during exercise occurs in a joint that is less inflamed and therefore less pain inhibited, allowing fuller muscle activation and faster strength gains. The bedtime compounds from our relief video reduce the overnight inflammatory activity in the joint, meaning each morning's exercise session begins from a lower inflammatory baseline than it would without the nighttime protocol, and the exercise itself by stimulating synovial fluid circulation, increasing muscle protection of the joint, and producing the post-isometric analgesic effect creates a joint environment in which the nutritional interventions can work most effectively. This is the integrated strategy: exercise protecting the joint from mechanical damage, nutrition protecting it from inflammatory damage, and the two together creating the most comprehensive natural knee arthritis management approach that the current evidence supports. Your knees are worth this investment. After 50, every day of consistent practice compounds in its benefit. The quadriceps strength you build this week protects the cartilage you depend on next year. The proprioceptive control you train this month prevents the fall you might otherwise have next year. The habit you establish this morning is the protection you carry into every morning for years to come. 7 exercises, 30 minutes, every day, starting now. If this video gave you a specific, practical, evidence-based 7 exercise routine for your knee arthritis, please support this channel. Hit the like button right now, subscribe if you have not already, and leave a comment below. Tell us which of these 7 exercises you are going to start with today, and whether you have been avoiding exercise because of knee pain. We read every comment. Your commitment to your knee health matters deeply to this community. Start today. Your knees are asking you to. Thank you so much for watching. See you in the next one.